Thank you very much. It's a pleasure being here today, and thank you for coming on a Saturday morning to learn about MS. And one of the things that we always talk with colleagues is that probably MS patients are the most educated patients in the entire field of neurology. And this is a clear example why, because there is a lot of interest from our patients to keep learning and keep taking control of their disease by having knowledge. So those are the list of objectives that I want to talk to you today about MS. I want to give you a brief summary of what we know about the disease, how we diagnose the disease, and also recent therapies that has been developed to treat multiple sclerosis. And along with that, I will not talk too much about efficacy because that will be covered by the last talk with Dr. Ballmer. But I want to talk about safety concerns that should be taken into account, and they are as important as efficacy concerns when we choose therapies for our patients. Just to give you an overview of numbers, we know that MS is a very common disease. Over 400,000 Americans live with the disease. In Colorado, we estimate that it's approximately 12,000 patients with multiple sclerosis. We do have a very active clinic at the Rocky Mountain MS Center in Anschutz, and we do see over 6,000 visits per year. That's just in Anschutz, and we, as Karen mentioned, also have clinics in MCPA, in Denver Health, and in the VA. So the total number of patients that we see in the clinic probably is 1/3 of what we estimate the number of patients are in Colorado. It's a disease that affects usually young people, or starts with the symptoms in young people, and as you hear in the video, we see patients anywhere from childhood to elderly. And at any stage in the disease, and every stage of the disease, there are things we can do to help to not only stop the disease from progressing, but increase quality of life to our patients. We know that if the disease is not treated, the disease will most likely go into progression, and with that progression means disability or functional loss to our patients. It is a very costly disease to the healthcare and to patients. So we have to be taking those factors into account when we design treatment therapies for patients. So what we want to do is to choose the right therapy at the right time. And we know that MS is the leading cause of disability in young females, and also the second cause in young men in the United States. So it's a very serious disease. What causes MS? You heard from Dr. Jackson that we don't know. You also hopefully got a sense of how advanced research is happening at the molecular level in multiple sclerosis. What I'll try to show you today is also research that is happening at the clinical and MRI level in multiple sclerosis. It is multifactorial. We know that multiple factors will play a role in increasing the risk of developing multiple sclerosis. Has been speculated that virus like Epstein-Barr virus or the culprit of mononucleosis infecciosa could be a factor that may increase the risk of multiple sclerosis. In terms of other environmental factors, vitamin D and vitamin D deficiency has been shown to have a link to both the risk of developing MS as well as prognosis in patients who already has multiple sclerosis. Patients with MS with low vitamin D levels do worse than patients with normal vitamin D levels. And the levels that we try to aim in clinic is levels between 50 to 70 nanograms per deciliter. So that's something that every patient with MS should have their vitamin D levels checked in the clinic and discuss with the doctor how much vitamin D they should take in case they are deficient. We also know that smoking cigarettes increases the risk of disability in patients with multiple sclerosis, and we know that loss or lack of exercise or physical activity also make the prognosis worse. In terms of dietary supplements and diet in MS, there is little research other than the research done in vitamin D, as well as omega-3 fatty acids that they might be beneficial for multiple sclerosis patients. So this is how we usually exemplify the clinical course in our patients. And what you can see here is that the typical or most common presentation of MS, and I guess I should stay here, is it will manifest clinically with what we call relapses. And relapses is nothing else but just sudden onset of a neurological deficit, weakness, numbness, loss of vision, loss of balance, coordination, you name it. That lasts for at least 2 days and slowly will get better. And that is represented here. So you have the deficit, then the deficit goes away, and you go back to normal. But the truth in clinical is that every time a patient has a relapse, after the relapse, there is not a complete recovery. There's always some sort of disability that starts to accumulate. At first, maybe that disability is subclinical. Patients might not notice that, but we know from studies that there is always some sort of disability that is left after each relapse. That's one of the reasons why we try to avoid as much as possible and prevent the development of relapses in our patients. As you know, as the disease progresses without intervention, it's going to come a point in which disability to continue to accumulate in a very steady way. And that's what we call or label in clinical practice secondary progressive multiple sclerosis. What is important to recognize is that natural history studies, large-scale studies, showed that once patients reach this level of disability, usually the progression of the disease will continue and it's very difficult to stop. However, we can modify that rate by applying certain therapies. Those studies also show that the more aggressive we are in stopping progression early on in the first 5 to 10 years of the disease, the better the outcomes are at later stages of the disease. So MS is giving us a window of opportunity early on to try to apply very effective therapies to prevent development of relapses and to prevent development of brain damage. In the lower part of the chart, you see these yellow arrows, and what they represent is lesions or MRI activity on the brain or spinal cord. And but the first thing that you can understand here is that even before the first relapse, patients have lesions on the brain. Most of those are asymptomatic, meaning they don't have or they don't represent symptoms. Sometimes the patients might have an MRI of the brain because of other reasons, because of a car accident or headaches. And we encounter those situations that they did an MRI and we see that there are MS lesions. And those lesions occur years before the first event. That is something that we call radiologically isolated syndrome, or RIS. What is also important from this graphic is that you see that the MRI activity is way more evident and aggressive than the clinical activity. On average, 1 out of 10 lesions in the brain will cause symptoms. And that's a very important concept to remember. Even when you feel that you're stable and you're on a given therapy, we still want to do MRIs to make sure that there are no new lesions developing over time. Because again, only 1 out of 10 lesions on average will cause symptoms. So patients could still develop lesions in the brain without noticing any new symptoms, and when we do physical exam, we don't notice any new deficit. However, we do MRIs, and it's possible to see new lesions. And we should act or take those lesions into account when we decide what to do in terms of therapies. So it is estimated that prevalence of MS is approximately 30 over 100,000 patients, and that's globally. And there are certain regions that you can read in this slide that seems to have a higher prevalence. So it's been speculated multiple theories to explain why certain regions in the world will have higher incidence of multiple sclerosis. We talked about the importance of vitamin D and maybe vitamin D deficiency areas with lower exposure to sun or sunlight may be involved. However, we know that in Colorado we have enough sunlight and yet we still have a high incidence of multiple sclerosis. Maybe the altitude, maybe another environmental factor may explain. When you look at the map of the world, you see that red, orange or pink and yellow are areas with higher incidence, red being the highest. And United States and Northern Europe and Canada, those are areas in the world with high incidence of multiple sclerosis. So is this just climate related, is this just altitude related, or this is also another environmental factor? So there was a theory that is being proposed, and actually it's been now studied with several clinical trials, called the hygiene hypothesis, in which looks at the prevalence of perinatal or infantile infections early on in life as a way to promote a mature immune system that is going to be less prompt to develop autoimmunity. say it in different words. In countries with poor sanitation, like in most countries in South America or in Africa, we see that the incidence of autoimmune disorders is lower. And one of the explanations for that is maybe the presence of poor vaccination campaigns and increased incidence of certain infections early on in life might prevent certain immune responses that may be autoreactive in the future, causing autoimmune disorders. This doesn't mean that we shouldn't vaccinate our kids. This doesn't mean that we should promote infections in childhood. However, this could be an interesting point to look forward, and as a matter of fact, there is a trial looking at a parasite that may trigger a response in the immune system that may be protected for multiple sclerosis patients. So this trial is going on in Europe, and we are all hopeful to see benefit or good results. And of course, people will not be asked to eat parasites. Will most likely be developed in a vaccine form. So we already talked about this. I wanted to show you is that many studies show that whatever happened in the first 5 to 10 years is somehow going to set the clock and will impact in disability later on in life. So that's a very important window of opportunity. That doesn't mean that in patients with MS for over 20 years, there is nothing we can do. There is always something we can do. So how MRI play a role, a very important role. We already talked about the role in monitoring the disease in patients even who are asymptomatic. Also it's very important, as you all know, as diagnostic for multiple sclerosis. I'm sure all of you who has MS at some point had an MRI early on in the process of diagnosis. And it's also a very important research tool because allow us, Lila Jackson talked about the lack of good animal models, and that's true in MS. So we can't ask biopsy for brain of our patients, but we can take pictures of the brains, and that's what we are doing with MRIs. And sophisticated techniques that are not available clinically are allowing us to understand the process in vivo of what is happening in our MS patients. So this is what an MRI in an MS patient look like, and this is just a horizontal view, the catheter in this way, and you can see the brain. And inside the brain you can see those are where the brain cells live, the neurons live, and the gray is normal. However, you can see these patchy areas of white signal, and those are around what we call the ventricles inside the brain, which is a fluid-based space. And those are what we call the periventricular lesions, and those are very characteristic yet not specific for multiple sclerosis. So this is a very complex slide, and I will not cover every single point of that, but just to show you that the diagnosis and the criteria used to diagnose MS keeps changing. There was a set of criteria done in 2001. They reviewed them and changed them in 2005. They reviewed them and changed them in 2010. And we are always waiting for the next revision, and we are part actually of that process as well. So it is a very complex disease to diagnose. It is, as you may know, not straightforward in many cases. So we need to follow international criteria to diagnose multiple sclerosis as well. So let's move now to trying to explain what are those lesions and what is the mechanism and also the importance of looking at those lesions in the brain. So this cartoon shows what a brain cell looks like. This is the body of the brain cell or the neuron. Those are the dendrites, communications that the neuron will have to other cells. And keep that concept in mind because we'll go back to talk about the dendrites and the communication of neurons in future slides. So those, what they look like, is just simply projections of the cells that tries to reach other cells and talk to them and communicate with them. So after that, you have the long projection of the cell called the axon. And the axon can be meters long. The axons that go from the brain all the way down to a nerve in the toe can be very, very, very long. So those axons are going to be wrapped around with a fatty substance called myelin. So what happened in MS is that this is a nerve cell, that's the axon, and that's a muscle. So in a cell that is trying to move muscles, normally you have the myelin that for some reason in this cartoon looks like a hot dog, but actually that's the axon, and I couldn't realize why, but looks like a hot dog. And then you have the myelin around. So in MS, the immune cells will come to the brain and destroy the myelin. So now the axon becomes naked. And that could be one of the explanations that Laila was talking about, this epitope spreading. Now you're exposing different antigens to an environment that is not used to see them because they were protected. And now those new antigens may trigger even further immune responses inside the brain. So this is what a wire looks like. And I'm trying to explain what happened when we have demyelination and what happened when we have axonal loss. So a wire is, or a nerve is like a wire. You have the copper wires going inside, and then you have the protection or the plastic that in case of the brain is called myelin. And the copper wires are called axons. When you have demyelination, you lose that coating around the nerve, and now the axon becomes exposed. If you do an MRI in that patient, you see these white dots, and that's what we call the white matter lesions. But in MS, patients can also have a transection of the axon, a complete interruption on that particular axon. If we do an MRI in those patients, not only you see the white dots, but also you see these dark lesions, and that's what we call the black holes. It is a horrible term, but we still use that. And I always encourage patients to be aware of not only the lesions they have, the number, what happened over time, but also the presence of black holes. And why is that? Because those are the lesions that we as physicians should get worried if we see a continuous progression of accumulation of lesions or black holes in the brain. Those are lesions that we have little hope for recovery, little hope for repair, that the brain will go back and try to remyelinate. So this is one of those variables that will look not only in terms of prognosis, but also how we monitor disease. Usually we expect that black holes should be approximately 30% of the total number of lesions. So in a patient with 100 lesions, 30 to 33 should be black holes. If we see more, we probably should pay attention to that. And I'm sure you're also familiar with contrast-enhancing lesions if you received a report from the MRI. And that's the way they look, very bright after they give you the contrast. And the meaning for that is that the lesion is brand new, a lesion that occurred within a month of the time of the test. We'll look at them also very carefully because those active enhancing lesions are telling us that probably that therapy is suboptimal in terms of stopping disease from progressing. We talked about this, and this is just to show in graphics and in pretty colors the fact that we know that after each relapse, there is accumulation of disability, even if patients don't feel it. If we do certain tests in the clinic, you see that after each relapse, there is this progressive accumulation. So we need to stop relapses. We talked also about the importance of MRI in progression of the disease, and several studies showed that the number of lesions that occur and the rate of progression or the rate of development of those lesions in the first 5 years of the disease somehow will set the clock and start to trigger this chronic progression of disability. So a patient, for example, starting the disease when they're diagnosed with 10 lesions, but in the first 5 years develop 200 lesions, that patient we should be worried about because we know that that process will continue in a very aggressive way. In a different scenario, a patient that starts with 200 lesions, but over 5 years only had 2 new lesions, probably that patient will do better. So it's not only important to know the number of lesions, but also how fast those lesions accumulate over time. And that's something that, again, it should be discussed with your doctor in each visit. Brain atrophy is important. We know that we all go through brain atrophy. That's called normal aging. And interestingly, men's brain atrophy faster than women's brain. And I will not go there. But the truth is that MS patients without therapies, we know that that rate is also accelerated. And that's one of the reasons why we want to treat MS aggressively early on, to try to stop this atrophy from progressing. Ultimately, atrophy means that we are losing brain cells. So those neurons, we are just losing them. And the brain is one of those organs that we cannot create new neurons. Certain places in the brain we could. However, overall, it's one of those organs that is very limited, the ability to create new cells. So we need to preserve them as much as we can. Again, exercise, healthy diet, and intellectual activities is the best way we have to use those cells that we have available and to keep them healthy. So this is again to show you how confusing is the field of multiple sclerosis from a clinical standpoint. What I did here, I pulled 4 examples of clinical trials, well-designed international studies with thousands of patients and dollars for each study. Yet, the way they define suboptimal response to therapy is completely different in all of them. So, of course, the results are going to be different, and they represent different explanations of how they look at suboptimal response. So what I want you to get from this slide is the fact that there is no agreement in the MS community of what we call suboptimal control of the disease. Is one new lesion in the ear something that we should worry and change therapies? Are 10 new lesions something that we should worry? 3 relapses and so on and so forth. So this brings a very important point. Every patient is different, and every situation is different. And every patient in different stages of the disease will behave differently. So your doctor should take you on an individual basis. Maybe a lesion, one new lesion in a patient is not a big deal. One new lesion in a different patient is a lot of concern because that's in the wrong place. So I need to explain to you what is cognitive reserve and cortical reserve and why we care about lesions. And I thought to make an explanation based on a city, because ultimately connections in the brain are like streets in a city. So connections, those axons, will try to communicate 2 points in the brain or between the brain and the organs. And I thought to bring the map of Denver so I can at the same time learn my geography here. So for example, let's say that you want to go from Aurora and you want to go to Golden, so you will take the shortest route unless you use your GPS that will take you all the way around. So, and the brain is lazy. The brain will try to use the minimal amount of energy possible to try to accomplish whatever goal they want. Remember that the amount of energy that we use per day for our brain is equivalent to a light bulb of 8 volts. Exactly, 8 volts, what we have in the fridge. So that's the energy that we use for our brain. And we have to do all these amazing things. We have to exercise, work, communicate. So the brain does an amazing job of trying to be lazy, try to use a minimal amount of energy to try to accomplish whatever function we ask the brain to do. So of course we'll take the shortest route. So you take I-70. Let's imagine now that you have a lesion in I-70. So the brain will say, well, we have to move to a different way to get to Golden. I still want to go to Golden. So we'll take slightly longer route. If you take that to an MS patient, well, the MS patient has a lesion in the pathway that moves the pinky. But that patient wants to move the pinky, well, we take another route. The brain will redirect that communication through a different pathway, maybe slower. And that's why the patient feels somehow clumsy, because it's not right. Let's say that then you have another lesion in that alternative pathway. Really bad luck, but could happen. So the brain will take another route and will try to use alternative ways to try to accomplish the goal that you are trying to do. That's in the brain, and usually in the higher part of the brain. As you get to the spine or the spinal cord, things are very narrow, very tight. So rather than looking at a map of Denver, we should be looking at the map of Tabernash. Anybody knows where is Tabernash? Very good. I love Tabernash. It's a small little town in the middle of the mountains close to Winter Park, but has this only US 40 as the main street and then small little streets. If you have a lesion in US 40, I can guarantee you the entire town will know about it. And that's equivalent to having a lesion in the spinal cord. Most of the time, lesions in the spinal cord will cause symptoms. And that's why that's one of those factors that we take into account. If we have a patient with a lesion in the spinal cord, we get worried because not only will cause symptoms, but also we know that lesions tend to occur over and over and over in similar places. So it's giving us this hint that if we let this process continue, most likely this patient will keep having lesions in the core, and that's bad news. So I don't know how I'm doing in time, but I just want to give you an example of all the therapies that we have available. 10 minutes, okay. So this cartoon tries to show this hot dog look appearance now became the blood-brain barrier, which is the barrier that we have that divides the brain to the rest of the system. And inside the brain you have the neuron, you have different cells that Laila talked to you about, the astrocytes, the microglia. And then outside you have the lymph nodes, and those are one of the organs that will produce and store immune cells. So what these therapies are trying to do is try to act at different levels. Some of those at the level of the T cells, like natalizumab, what it's trying to do is block the entrance of T cells to the brain. Rituximab is one of those B cell mediated therapies. It's a monoclonal antibody that will literally destroy the B cells. Alemtuzumab is a drug that is going to be approved probably in the next 6 months to a year. It's another monoclonal antibody that works at both levels, T and B cells. High efficacy medication with certain risks, including the development of autoimmune disorders. And this is a really complex concept to understand. How can an immune suppressive therapy that is treating an autoimmune disease can cause other autoimmune diseases? And probably the way to explain that is that by altering certain immune cells, those cells will probably regulating and suppressing development of other autoimmune disorders. By suppressing them, now we have the development of other autoimmune diseases like thyroid disorders and kidney problems. So very complex immunology behind this therapy, very effective therapy with some risks for our patients. We have oral therapies like fingolimod. What they do is they trap the immune cells inside the lymph nodes, and by doing that, they decrease the number of cells that are available to go to the brain and cause damage, and so on and so forth. So you can see with this cartoon that different cells will work at different levels. The two that we hope that we have some strong evidence that work inside the brain are laquinimod and BG12. BG12 is going to be the new kid on the block. And every time I use one of those expressions, I feel, I hope I'm saying it right. So I made serious mistakes before by trying to be smart. Anyway, so BG12 is going to be an oral drug, hopefully approved in the next couple of months. We are all impressed by the efficacy of the medication as well as the safety profile. And we know how the medication works, but we don't know how the mechanism affects MS patients. So a lot of research still has to be done for this medication. So let's now go to safety. And hopefully up until now I gave you an idea of what we look into therapies, what are the factors that we take into account to decide our therapies and also to monitor patients over time. I did not cover efficacy, as I mentioned before. That will be covered in future talks. But I want to give you a few minutes of safety. And as I mentioned before, safety is as important as efficacy when we choose therapies to our patients. And a clear example of that is a brain infection called progressive multifocal leukoencephalopathy, or PML, that occurs in patients who receive a medication called natalizumab or Tysabri. This brain infection is serious, is fatal in up to 40% of the patients. Probably recent literature in just MS, when we look, is only 20 to 25%. If you look overall literature in HIV patients, can be as high as 40%. We know that the virus that causes PML is a virus called JC virus. That's after the name of the first patient that was diagnosed with this disease. And as of June 30th, 2012, approximately 100,000 patients in the world received Tysabri. And of those, there's been 271, now it's a little bit more, patients that develop PML. So the advantage that we have now is that we can test whether our patients carry the virus, the JC virus, and I will talk to you about that in a minute. So we are getting more and more educated in clinical presentations of PML, as well as in treatment. However, most of the treatments that we have tried failed to significantly change the course of the brain infection. So it's one of those disorders that we want to avoid as much as we can. So this is just a breakdown of the possible clinical presentations of PML in MS patients, usually with cognitive problems that is significantly worsening of cognitive problems, not just occasional memory loss, but something that is obvious and a sudden onset of a worsening of that. And you can read the rest of the common symptoms. So the prevalence of JC virus, this is not PML, it's JC virus, the virus that causes PML. We know that it's approximately 50% of the population and depends on the age. As we grow older, the risk of developing JC virus infection is higher. And that risk is estimated as 2 to 3% per year. So all of us here has a 2 to 3% risk of developing a JC virus infection. Again, that's not PML, that's just getting the virus in your system. That virus infection usually is asymptomatic. You will never know that you had it. It's very difficult to prevent because the virus is everywhere. So usually we don't recommend any special measurements to decrease the risk of infection with JC virus. Once a patient has the virus in the body, usually nothing happens unless the patient becomes immune suppressed or we use Tysabri. So that's why these tests should be done in every patient before deciding on Tysabri, and once the patient is on Tysabri, every 6 months to make sure that the virus remains or the status remains negative. As a rule of thumb, Tysabri should be considered in the right patient when they're JC negative. Patients that are JC positive, we usually try to be cautious on the use of this medication unless it's absolutely necessary. And in those patients, we try not to go beyond 2 years of therapy because there is another link to the risk of PML, not only having the virus, but also how long we use the medication for. So this is just to give an idea that depending on the duration of therapy, less than 2 years, more than 2 years, JC positive, JC negative, and there's another factor is prior use of immunosuppressants. So if you have 3 out of 3, so JC positive with prior use of immunosuppressants and over 2 years, you're in bad luck. That's a risk of 1 in 100 of getting PML. So we will never go there with our patients. On the other hand, the best clinical scenario will be a patient that is JC negative without immune suppression and has received natalizumab for less than 2 years, and that's a very, very, very low risk. It is less, actually, that should be less than 1 in 10,000 patients. Just to give you an idea, it's lower risk than dying from a car accident if you drive every day. So, and just moving to the last risk stratification that I want to discuss with you is the risk of Gilenya or fingolimod in our patients. As you know, this medication was the first oral drug approved. And since then, when you look at clinical trial data as well as post-marketing, we have approximately 36,000 patients that received the medication, whether it's on clinical trials or post-marketing. And of those, there were 31 deaths. Of those, the ones that are concerning are related to cardiovascular problems, and with myocardial infarction or heart attacks in 3 patients, arrhythmias and sudden death from multiple possible explanations, anywhere from a car accident or a patient who drowned in the bathtub. However, the autopsy did not show any evidence of clear link with the medication, but the speculation is that, well, maybe the patient had a heart attack and that's why she died in the bathtub. So it is still under investigation. Probably we will never have a clear answer to that. But the truth is that there is a link between the use of this medication, particularly in the first dose or during the first month, and the development of low heart rate, something called bradycardia. And actually the more concerning piece of that is that the communication between different chambers of the heart might be impaired, something called AB block, and that could be linked to sudden death or arrhythmias. So as a rule of thumb, and the FDA reviewed these cases and came out with new recommendations, we don't use the medication along with any medication that can lower the heart rate. The most common ones are antihypertensive medications, beta blockers or calcium channel blockers. Or we don't use the medication in patients with cardiovascular risk factors. So, and this is the last slide, and just to give you an idea that there are new therapies coming, as we discussed. Teriflunomide was recently approved. I have to actually change that in the slide. was recently approved. Laquinimod is, they are all oral therapies, and alemtuzumab is an infusion. They do have some side effects. For example, with teriflunomide, it's a relatively modest efficacy, around 30% reduction. But some side effects, including nausea, vomiting, diarrhea, and hair loss. And believe me, I'm very sensitive to my hairs. So I feel the pain of my patients. I don't want them to lose hairs. But that could be a concern, or hair thinning, actually, that the company is trying to say. But the truth is that could be a concern, but it's a good medication. It's a pregnancy category X, so that means that we shouldn't use it in pregnancy unless we have more information about it. But it's good to have it. It's an option, and it's an oral therapy that could be a very good choice for some patients. Laquinimod is not approved. Probably more studies will happen to try to understand better the mechanism of action. But it's, again, we are very excited with this medication being hopefully soon available. BC12 for dimethyl fumarate. That's a medication that we are waiting. Hopefully will be the next one approved in a couple of months. The mechanism of action is very interesting. As I mentioned before, we still don't know how that mechanism of action could alter the course of the disease. But in terms of efficacy, showed very exciting results. In terms of safety, not major side effects or concerns. Seems like flushing after taking the medication, particularly early on, might be the most common side effect, and usually gets better with aspirin, so might not be a big concern. And some animal data shows some GI malignancies that we need to further look at, but nothing concerning in humans. And as I mentioned before, alemtuzumab is going to be a very effective medication, hopefully available in the next 6 months to a year. It's an infusion. It's probably the best infusion schedule for patients because it's 5 days in 1 year and 3 days in the following year and nothing else. So it's very convenient from that standpoint. There are concerns of the medication triggering autoimmune disorders, as we mentioned before, from this imbalance of certain immune cells. So more to come, but will be a great medication to have available for certain patients. So this is just to summarize, learning points. Frequent follow-ups and MRI are important to monitor your disease and discuss those with your doctor. JC virus restratification is an important tool in patients who are considering or are on natalizumab therapy, as well as monitoring certain risk factors like cardiovascular risk factors in patients on fingolimod or Gilenya. Thank you very much.